welcome to the Stronger After Stroke podcast. My name is Rosa Hart. I'm the stroke nurse navigator for Norton Healthcare, and with me today is Cheryl Young. She's a licensed marriage and family therapist, and she's certified in chronic illness. So she has been an integral part of our team in taking care of people after they've had a stroke. So stroke survivors often experience anxiety and depression. Where do you think those feelings come from, Cheryl?
Well, thank you for, actually, anxiety and depression seem to be coming from a deeper place. They're usually symptoms or come after something deeper. They're just results of a fear or an anxiety, a fear or worry that's buried underneath the surface. And often I talk to clients and they want to deal with their anxiety, but we really need to get to what's underneath that anxiety and how to calm that down and address it and heal it, sometimes from long ago trauma that has affected them.
So it might not be just fear of having another stroke then.
The anxiety may not be, but the fear is usually something, and I kind of relate it to, we all have these hidden secrets that we carry around with us, or baggage, or that we just kind of keep the family secrets or our secrets that we don't think anyone needs to know. So we hold on to those pretty secretly and safely, and we tuck them, sometimes I say like a beach ball underwater, you're holding it down, and you can do that until something like a stroke comes along, and then all of a sudden you have to take your eye off the ball for a second, and then everything shoots up. So I think we all have that, and we can manage it for a while. But when something like a stroke event happens to an individual in a family unit, those other things tend to come up to the surface.
That's a good point. And it is not just about the one person who had the stroke, it affects the whole family.
Absolutely. And I am a systemic therapist, so I do look at the whole family system or the support system of the person living with the stroke, so that we can address everyone's new way of living.
Yeah. And it's important to address it as a village, right?
Absolutely.
Because everybody needs a village.
Absolutely. And I think there was a small study done that showed the person, it was not with strokes, but with chronic illness, was diagnosed with the illness, and the family member. And actually the family member had higher incidence of fatigue, depression, and anxiety than the person living with the symptom or the disease. And so recognizing that, and then the aftermath was getting some therapy or some interventions done, really brought them both back down to livable levels.
Yeah, definitely. Because you can have one person in therapy, but then if the person they live with is so super stressed out, there's only so much that they can do, right? It really needs to be a group thing.
Absolutely. At some point, I usually bring the whole family in so we can work together.
That's so awesome. So how do you talk people through the process? Do you ask them about their life before the stroke?
You know, I think it's interesting because it's very easy, and certainly newly, after a stroke event, that's all we're focusing on is that stroke. And as you mentioned, the fear of another stroke and what caused that, and they come out of nowhere. So once we have a few sessions and we can get some trust established and some calmness and learn how to teach how to calm ourselves down, we try and explore what were you like before the stroke. So sometimes I do what I call a miracle question. If you were to go to bed tonight and wake up and this burden was lifted from you and everything was fine, what would that look like? And what does that look like? So we don't only focus on the stroke and maybe that some of the limitations it may have caused or the fear and the anxiety, but we focus on life before the stroke and where we want to go after the stroke.
So they can even visualize that and get a picture in their head, because maybe they're only visualizing worst case scenarios.
I think as humans, we tend to catastrophize situations. And it's legitimate. Our brains want to protect us. They want us to, go to fight, flight, and freeze. If we're endangered, we need to get that signal. But our brains can't understand the difference between a real threat and a perceived threat. And so often after a traumatic event like a stroke, and I consider that traumatic to the psyche as well, People will go to the catastrophizing and the what if and I can't, and they'll place limitations on. So it's important to be able to take some deep breaths and go to more of a rational thought process.
Yeah. So can you talk us through one or two of those processes so that people listening can get an idea of how they can self-regulate?
Absolutely. I'd love to, because it's a really great place to start. And it sounds super simple. And so I want to share with you that it honestly works. I always talk to clients, and if you're able to just recognize, be where your feet are. Where are your feet right now? Especially if you're into this cycle of worry and what if, and I can't. Take a deep breath and where are my feet? And then I do the 5 senses and try and ground yourself by being present. 5 things I see, 4 things I hear, 3 things I touch, 2 things I smell, 1 thing I taste. And I encourage people to do this on a regular basis and not just as a rescue type intervention, because our bodies need to learn how to self-regulate on an everyday basis. I do it when I'm out on a walk, because otherwise my mind wants to race down. I've got so much to do when I get home. I have to hurry, and it defeats the purpose of the relaxing walk.
Yeah.
And studies have shown really that the more you practice mindfulness practices like self-regulating and grounding, the benefits are just incredible. But it works if you do it. It's a practice. It's not a one-time and done.
Exactly. And then I believe you are trained in EMDR as well, right?
I am an EMDR, and that is,
what does that mean?
Eye movement reprocessing, desensitization, and reprocess. We reprocess. So we work on. It was actually developed, and it's empirically based. So again, there's a lot of research supporting the efficiency of it or the efficacy of it. It reprocesses maybe negative core self-beliefs. So when you had the stroke, I'm just going to make up a situation.
Yes.
A stroke, person living with a stroke aftermath might be saying, I should have taken better care of myself. I could have done this, or if I didn't do that, and going through and have this negative core belief that results in shame and regret. And that can really keep people down and stuck and depressed. So we would reprocess maybe some of those memories. We do a targeted sequence. We target a memory that maybe where they thought something significant happened. And I ask them to reprocess that. We activate the brain, and we process that back and forth for a period of time. They're called sets. And then we reprocess that with more positive, adaptive belief statement that I did the best I could. I didn't do this on purpose, or I now know better. Now I can do better. I will be okay. I'm going to take better care of myself. Reprocessing that so that they can leave with a positive core belief. And that has been very effective to help shift out of a negative self-belief.
Yeah, that reframing of your own perception of how things are can be so powerful.
And again, yes, it's very powerful, and it's very highly effective.
Yeah. So when a stroke changes the role we fulfill, how does one adapt to live in that role in a different way while maintaining their connections and relationships?
Absolutely, because everything changes. We go through this life, and I'm typically, I guess, what is an average age of a stroke patient? Somewhere.
Well, children have strokes.
I know that. That's why I hesitate to say that.
So I don't actually look at pediatric data in my job. I work with adults, so I can't really
target it. I thought about that when I said that.
And I actually just interviewed a stroke survivor who was in her 30s.
So it's at any age, but we all adapt into these roles along our lifespan.
Right.
So when we're younger, it's a student. We're a student and a child, and we're, a friend and, different relationships, and a niece or a nephew. And then as we grow older, we have different roles that we just assume. We roll into them. They are adapted to us.
Like you become a mother.
Right. A mother, yes, a nurse, a therapist. We have these roles that we take on, and we kind of don't think about it until something like a stroke happens. And those roles tend to shift may shift. They may not, but it's good to identify who am I and who am I to all these people? Who am I as a person? And how can I shift, maybe make some adjustments? So I am still a nurse, a therapist. I've had a stroke. I'm not a stroke survivor that is no longer a nurse or a therapist. I'm able to still maintain my role as a mother or a partner. And so I usually have clients write out as a homework assignment, who am I? And it comes back sometimes with a really long list if they do a lot of thoughtful reflection. But then how we can still be those people, and what does it look like now with if I have some limitations? What does it look like to be, instead of the breadwinner, the person who needs help now, instead of the caregiver, I need to be taken care of. How do we shift that and adapt into those roles?
Right. And then some people might say that they have a better relationship with, say, their dad, who was maybe of a workaholic tendency, and now he's home all the time and can spend time with them. They can play checkers together or whatever, and they have a better relationship in that role change, even though it may not be the way they found their identity in being a father before. Now that they have more time to spend that quality time with their family, they can still be a father. It just looks different.
I wholeheartedly agree. And I try and be careful with this statement because I don't want to be dismissive of the feelings, but I kind of work with acknowledge, accept or allow, and then appreciate. Because you get to a stage where you start appreciating, no, I didn't want to have this stroke, but if I wouldn't have met these friends in my support group. My relationship with my spouse we would have gone on different paths because we're so busy. We've been forced to look back and adapt and modify our roles.
Yeah.
And I think that takes almost like 4 years to really settle into the new rhythm of your relationships. And that's a rough estimate, but most people say it just happened a year ago, it's happened 2 years ago, but it really takes some time to get really into it and feel your feet on the ground and start being present again, because you're just adapting to this new change.
Yeah, there's a lot of perspective changes that come with having a stroke. A lot of people feel invincible before it happens to them, and that's what I've heard is just it shakes people up, and to not be that invincible person they thought they were. And
absolutely. So
who can someone reach out to if they are experiencing these feelings after a stroke?
At first, I want to affirm that not feeling settled is completely understandable.
Right.
And so acknowledging that and saying, this doesn't feel good anymore. I used to really like this relationship, or something has changed, and acknowledging it and saying, let's do something about it. Reaching out to their primary care and saying, I always like to do a first health checkup. Is everything okay from a medical standpoint? And to reach out to a therapist. Talk therapy is shown to be very effective. There's certainly different. I'm a marriage and family therapist. There are licensed clinical social workers or licensed psychological counselors. There are all kinds of different professional therapists available. The best way to do that is to check your insurance card and call and ask who's in your network in your area. So talking to your doctor and seeing if you can get in with a therapist who hopefully has some experience in chronic illness or stroke.
Right, and your primary care provider may be able to recommend someone in your area with that specialization. Like we had a certified sex therapist on this podcast on some other episodes. And so having that personal connection to someone local might be a good resource as well.
It is certainly understandable and advised to screen out your therapist because not everyone's a good fit for everyone.
Right.
In this area, we have Psychology Today, and I'm not sure if it's a national system, but people can go on and read our bios, what we work with, insurance we take. So there's usually a format that people can go and check, or call and interview the therapist. Are you familiar with this? Have you done any work with this? No one should be offended by that.
Right.
I absolutely. And if people often ask when starting therapy, how long does this take? Therapy takes a little bit of work, and I always, encourage to kind of do some pretty intensive work up front and then start spacing out sessions so that we develop a good rhythm to our time and trusting relationship.
definitely. So if someone were to need a psychologist or psychiatrist, how could they tell the difference between a psychologist and psychiatrist, for example?
That's an excellent question. So my profession, and a licensed clinical social worker, we can't prescribe medication. We can certainly diagnose, but a psychologist would do assessments. They tend to do more assessments.
Like what? You would be doing an assessment and diagnosing.
I do an assessment as well. A psychologist does a battery of assessments, maybe if they're looking at ADHD or autism or something along those lines more.
Neurocognitive.
Yes.
And like a 6-hour battery.
Yes, right.
One right after
and
the other.
I've had some stroke patients go and have a cognitive eval afterwards, just to understand what part of it is part of the stroke and what part of it is just aftermath of trying to accept it. And that's been helpful.
Good.
So a psychiatrist does a lot, and they do talk therapy as well. A psychiatrist is the medication management, and they're specifically trained in the brain science and what medications work well for if it's anxiety or depression. There are very different methods of connecting those neurons with medication, and they are the ones that are specifically trained. Oftentimes a PCP will prescribe, and that's fine. But if you're not feeling you're getting the results you want, I would always recommend finding a psychiatrist or a nurse practitioner who specializes in psychiatry for medication management and assessment.
Yes. And then maybe the primary care does the refills once you get a good balance or something like that long term.
And it takes a little bit of time. This is not a
think it
sprint.
Takes 6 weeks.
6 to 8 weeks.
For an SSRI, which is an anxiety and depression medication type, to be at its
therapeutic
level in your body.
And so I just always ask people to be kind to yourself during this aftermath of a stroke and long term. Be kind to yourself and also trust your insight and your discernment. If this doesn't feel right, you are the expert. You're going to experts, but you are the expert on your body, and feel absolutely to say, this isn't working for me. What can we do differently? Sometimes I ask clients to keep a 1-sentence journal because I don't want them to hyper-focus on problems, but do a 1-sentence journal of today I felt good, bad, sad, mad, whatever, and just kind of see if you can see a rhythm or some type of, pattern. Again, not to keep it, 30 pages or 3 pages or 30 minutes, just really especially as you're kind of getting used to it, because we kind of forget. Yeah. And then we go to our provider and how have you been feeling? Well, I think okay. And you forgot that you had 2 weeks of really bad weeks. So it's helpful for both the provider and yourself to see what your patterns look like. Yeah,
definitely. And so I have encountered lots of patients who say that they're concerned that they don't want to take any more medicine than they have to. They already had to start on these stroke prevention medicines, or they're afraid of the stigma of being on anxiety and depression medicine forever if they start.
And I hear that often too. And I'm hopeful that stigma is starting to lessen after post-COVID. I think it's becoming more available to talk about your feelings and anxiety and depression in particular, and also know that these are situational medications. They're to go in and help kind of, I say, untie your hands from behind your back so you can start breathing and living and looking around and seeing what's good. They can be temporary. They may be lifelong, but they aren't necessarily. They're intended to help get you through a bump in the road, to even things out until things start flowing a little bit smoother. And again, I go back to pay attention to how you feel, and do not stop the medication on your own.
Right.
Do not stop the medication on your own. Many of them have serious side effects of doing that. So work in conjunction with your doctor. If you say, I think I want to taper off, certainly do that. But I would give it at least 6 months, 8 months, a year to see the benefits if you're benefiting from it.
And it might just help reset your brain and help you move past the scary new stage in life when you're learning about what is it like to live after stroke. Absolutely. And not let that fear hold you back from doing things like participating in your therapy that's going to get you stronger.
Right.
And help you get out of the house to go to your doctor's appointments and support groups that can help you. And then if you want to get off the medicine later, then you have all those support infrastructure that you were able to get out of the house and do.
Absolutely.
Mm-hmm.
And I agree. I am a proponent of whatever it takes. I believe in good talk therapy and good support systems and medication management when it's deemed necessary or appropriate. There's no shame in any of it. It's becoming your best self.
Well, I really appreciate you taking the time today to share some of your wisdom and experience and talking to people who are going through these long-term issues.
Absolutely.
And to just let us know that it's a normal process. Like, this is something pretty much everybody goes through when they've had a stroke.
Absolutely. It's completely understandable.
So if this sounds like you, it's because you're not the only one.
Absolutely. And I typically, when I see a stroke client and I look at their medication list, if I don't see an antidepressant on it, I ask about it, because it really is, after any type of major event, depression usually shows up, on the radar pretty quickly.
Yeah.
And you don't have to suffer with it.
Yeah, definitely.
You do have choices.
Mm-hmm. Well, thank you for being a great option for people to talk to.
Absolutely.
And I think we've given a great list of places you can look for help if you need some. Feel free to check out our Facebook page at the Norton Neuroscience Institute and look out for our next episode of the Stronger After Stroke podcast.